Good morning, students. This is Dr. Herndon. I am going to be re-recording the Chapter 18, Eating and Feeding Disorders, Chapter 18 in Halter, in your Halter text. We have already gone over this in the classroom. I had recorded a collaborate that did not pull over from last year. So I'm re-recording this for your studying purposes and just to help you with going through this chapter. It's chock full of information that you'll be tested on next week. So, or the following week. I'm sorry, I can't remember exactly which day, but we will go through a review before the test. But your next test will include Chapter 18 as well as Chapter 24 that we just went over in class this past week. So this begins on page 332 in your Halter. It's about 17 pages. I would like for you to commit to reading this whole chapter thoroughly because it's got all kinds of good information for you that will help you to become an excellent nurse. So these are your objectives. Compare and contrast the signs and symptoms of anorexia nervosa, bulimia nervosa, and binge eating disorders. And so there are different criteria that must be met for these different disorders, and they do overlap some, and sometimes they're, they can be together. They can be, patients can be diagnosed with one or more of these diagnoses at the same time. So we want to make sure we go over that. Also, the other objective for this chapter is describe the biological, the cognitive, and the environmental factors associated with eating disorders. So this is a case study we'll look at throughout this presentation. Addie, age 15, is brought to the school nurse after fainting during gym class. She is grossly underweight. She wears baggy clothes and has dry skin. She complains of feeling cold despite wearing 2 sweaters. As the nurse examines her, she notices that Addie's skin seems slightly yellow and a gentle scrape of her skin shows signs of dehydration. So Addie has a few signs here that could be indicative of anorexia nervosa. First of all, she's age 15. The early adolescence is a prime time for especially females to go through this disorder, anorexia nervosa disorder. Males are less affected by it. And another indication is that she's wearing really baggy clothes, trying to conceal the fact that she is losing weight, that she is, not eating, and she is also showing signs of dehydration. So we're going to move forward. And the clinical picture here, the differential diagnoses are anorexia nervosa, bulimia nervosa, and binge eating disorder. So we'll look at all of these disorders and we'll continue this case study with Addie. So for anorexia nervosa, people who are diagnosed usually have an intense fear of gaining weight. They experience significant differences in sensation of taste over time because they're starving themselves. Their appetite is decreased, and their satiety is they don't crave food. They have a very early satiety of their satisfaction of the food they're eating. They don't have cravings of food because they're starving themselves. And after a while, from starving yourself, you begin to get decreased sensations of wanting food after a while. But these unique, unpleasant sensations help to perpetuate the disorder, and it leads to restrictive and sometimes restriction of food and sometimes purging. So we want to be aware of the symptoms as nurses so that we can kind of have an early intervention of the problem and early detection of the problem and early intervention for the adolescent going through this, because it gets dangerous after a while. So we'll move forward so we can look at this further. The body image of these folks, these females, usually females, it is very low, has a low prevalence in males. But the body image, when someone looks at in the mirror at themselves, they see a an obese person or an overweight person, when in reality their body is very thin and they're usually on the verge of starvation, of getting dangerously thin, of having metabolic imbalances, and these females, if they have begun menstruating, they will that will cease because they are not consuming enough calories uh, to facilitate the growth of the lining in their uterus, so they don't have a menses, they don't have a period, so that they get so thin that they stop having periods. The body will end up metabolizing the adipose tissues on their body. All of the adipose tissue, if it continues, the body will begin breaking down organs or muscle mass and then organs. So they will get very, very thin. And after all of the adipose tissue has been metabolized for energy, that muscle mass will begin to be metabolized and break down, and then after that, the organs may be next if this process is not halted. Okay, so really what's going on here is a decreased opinion or a poor opinion of themselves, um, and they disapprove of themselves for whatever reason. It may be that they are being bullied. They feel that they're not good enough, they're not perfect enough, they're not pretty enough, they're not smart enough, they're not talented enough. So many times this could be due to uh, bullying. We have today in our society, we have internet bullying, we have social media bullying, we have bullying in all segments of society. Even in nursing, we have bullying. So this is not a good thing. We need to have zero tolerance of it. And most organizations that you and I will work in as nurses will have a policy. It's usually called an incivility policy, where we have certain guidelines that we go by. And if the guidelines are not adhered to, then there are consequences for those types of behaviors. But at any rate, moving forward, the reasoning, the causes of this low self-esteem can be perhaps the adolescent goes through something. Maybe I know gym classes, gym students, not gym students, but students who are in programs such as dancing, gymnastics, um, ballet, different sports. They may emphasize thinness. They may emphasize fitness to the point where they may, discourage students from eating. And they're so hard on their students that the coaches are sometimes so hard and so rigorous that they may discourage these students from a normal body size or a normal uh, eating uh, tendency. So we need to be, as parents, we need to be alert, and as nurses, we need to be alert for these types of problems, because I do know of at least one incident where there was a gymnastics student whose coach was way over the top, being very strict, and she had begun to get a poor self-esteem, and then she had begun to starve herself. So, uh, and this is has been fairly recent, but just look out for this, and sometimes it has been perceived. There are theories that there is a lack of attachment for to one parent or both parents during the time that children are very small, from a very small age, and that's where it begins. But a lot of times it's not that at all. A lot of times it's just during adolescence something happens that will trigger this poor self-esteem, and then the disorder occurs from there. This is just a picture of a, a woman who has starved herself. She clearly has anorexia nervosa. She may have bulimia nervosa as well, but she has starved herself to the point that she has used all of her stores of adipose tissue. It looks as if she's also used her stores of muscle mass, and it also appears that maybe she is losing uh, her muscle mass in her organs. Maybe that she's her body is breaking down her cardiac tissue, because that's what happens sometimes, or all the time, if it's not stopped. If this disorder is not ended and remedied, and intervention is not has not occurred, then the cardiac muscle will be impacted, and they will end up in cardiac failure. So this is just a question, a practice question. What do we mean by the term purging when we talk about anorexia nervosa? Is it vomiting? Is it excessive exercise? Is it using stimulants or thyroid medication? Well, the answer is D, all of the above. Purging is a type of compensatory behavior. While most of us think of self-induced vomiting when we hear purging, it also refers to using excessive exercise as a means to use up the energy that we get from our food. Also, the use of laxatives is used as a method of purging our bodies, because we want to get rid of all of the food that we've eaten, to get rid of all of that in the colon and in the small intestines and then the colon, because we don't want that food to be utilized by the body. We want it to be eliminated so that we can be as thin as possible. That's what the people who that is their mindset of those who have disorders like anorexia nervosa. They use diuretics, they use stimulants, and they use thyroid medication aimed at decreasing weight. So the thyroid medication that they use would be Synthroid, or a type of Synthroid. They would likely get it from another person that they know. They would steal this medication to increase their metabolism, and to allow their body to be in a state of excessive metabolism so that they could lose weight. So the DSM, this is a manual. The DSM-5 is a manual that is used to diagnose mental health conditions. And I will try to think of the exact word for this. Okay, so it is a diagnostic and statistical manual of mental health conditions. And you may not have heard of this before the lecture. I know we went over it on Wednesday for the lecture, but it is a criteria manual that And for this anorexia nervosa, the criteria for diagnosing this is restricting energy intake to below requirements, and it has a significant, it produces a significant loss of weight and malnourishment. Also, intense fear of weight gain or persistent interference with weight gain. So they cannot bear to gain weight because they believe that they are obese and overweight. Also, disturbance of body image. They have a distorted body image, self-body image, thinking that they are obese. When they look in the mirror, they see an obese person and not the realistic reflection of their own emaciated body. They have a very, an unrealistic perception of what they see in the mirror when they look in the mirror. Um, they also have a self-evaluation linked to body weight or shape. And so they maybe their shape is just a very womanly shape. Maybe they have they begin with a frame that is very curvy during adolescence when they begin to experience these changes that are normal, but they see it as abnormal. They see it that they want to just be very uh, straight, thin, not womanly shaped at all, and that is a very unrealistic and unhealthy perception of what they're seeing in the mirror when they look in the mirror. Okay, so we will look at, okay, so there's a restricting type. So during the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior. That's in your DSM-5. And then binge eating or purging type. So this is a different type of anorexia nervosa in your DSM-5 manual. And the diagnostic criteria here is during the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging behavior. So it's looking at the last 3 months of this behavior. And so this is in your DSM-5. It's important for you to know this. It's in relation to the cause of anorexia nervosa. There is a lifetime prevalence of 0.5%. And this does not represent the actual prevalence, though, because we know that many of these are undiagnosed. We know that they hide many of these adolescents hide the fact that they are losing weight. And some families are just unaware of this disorder and they don't know what to do about it. They may not see it as a disorder at all. They may just see it as, normal. But the statistics reveal that fewer than 50%, seek help for anorexia nervosa, and individuals tend to conceal the symptoms. So they may wear such baggy clothes that no one knows how thin they are unless there's a reason for them to be seen without their clothes. So probably avoiding going to for their well checkups. They probably avoid going to the doctor, and so no one ever sees this in about 50% of the cases. So okay, so this commonly begins, as I said, during adolescence or in young adults. I know I mentioned in class that I did know a woman who had a miscarriage, and she contracted. She was experiencing anorexia nervosa. She was in her 20s, and she had that miscarriage, and it just kind of threw her in this, first of all, depression, and then it became somewhat like a post-traumatic stress syndrome, and she began to experience symptoms of anorexia nervosa, and she became very, very sick. She was hospitalized at UNC Chapel Hill. Her husband would have to recruit females to go into the bathrooms with her when they would be out and about, like at the hospital, for instance, for hospital visits or doctor visits. And I did run into them at UNC Chapel Hill, and he asked me to go in to check on her to make sure she did not purge after she had her meal. So it was very, very intense. She did end up being hospitalized, but she did come through it. She uh, conceived a fourth pregnancy, and after that, baby was successfully delivered healthy. She came out of that, so that was a success story. Um, but sometimes it doesn't end up in success. It ends up in death because their heart gives out. Um, okay, so many times with anorexia nervosa, we do have comorbidities that have that are uh, ongoing, such as bipolar disorder. We will talk about bipolar disorder next week, I believe. Also, anxiety disorder, depressive disorders, obsessive compulsive disorders, and post-traumatic stress disorder, which was what I described just on the previous slide. Trauma-related disorders also could trigger anorexia nervosa. Alcohol or substance use disorder is commonly a comorbidity that we see in anorexia nervosa. And then some of the risk factors include, for the biological factors, they include that researchers have found genetic correlations between anorexia, major depressive disorders, anxiety disorders, obsessive compulsive disorders, and schizophrenia. And they also found a correlation between anorexia and variations in glucose and lipid metabolism. So that's important to realize. Your cognitive factors include it is an egocentric disorder. That is, individuals value their disorder. So if they have this and they begin to enjoy it, I don't know. I mean, I have a problem conceptualizing that, but some people enjoy being ill, and they kind of attach themselves to the disorder, and it serves as an identity for them, I guess. And so they do value this, and they become where they enjoy having the disorder. Maybe they have attention from having the disorder, so they just enjoy it. They don't want to get rid of it because they like it. Um, Although they know that their actions are potentially harmful, they do believe that the benefits outweigh the harm because they get this attention and they identify with it, so then they just continue it. Environmental factors, it is associated with cultures that value thinness. So do we value thinness in our culture, in our society? We do a lot of the time. But I'm hoping that that is becoming not as prevalent as it has been in the past, that we embrace, embrace different body shapes and sizes, because there are different normal body shapes and sizes. And so it's not that, we should devalue people just because of their shape or their size. And some people are just I believe that some people are created to be bigger individuals, and others are created to be thinner individuals. And it's just a lot about heredity and things like that. So we'll continue. Our next objectives are that we will apply the nursing process to patients with anorexia nervosa, bulimia nervosa, and binge eating disorder. And then we will identify 3 life-threatening conditions stated in terms of nursing diagnoses in a patient with an eating disorder. And then we will identify realistic outcomes criteria for a patient with anorexia nervosa, bulimia nervosa, and binge eating disorders. Also, we will describe biological treatments and psychological therapies for eating disorders. So we're going to look at all the therapies, all of the also all of the medications that are used in these disorders, and those that are helpful and those that are harmful. Okay, so here we had the true story link to Karen Carpenter's story. She was a musician, a very, very successful musician. She had many, many hit records that came out in the 70s and 80s. And she rose to stardom, her and her brother. She rose to stardom, and she was very under a lot of pressure. Excuse me. Excuse me. She was under a lot of pressure, and we started looking at this in class, and we found out, I realized that it was going to take too long, so we didn't complete it, but you did see a few minutes of it. You saw the part where she went into cardiac arrest, and she was taken from her home and taken to the emergency room, and later died there, but from heart failure, because she had gotten so thin and starved herself so much that she had her body had metabolized all of her adipose stores and then all of her muscle stores, and then began to break down her cardiac muscle, which caused her to go into heart failure, and then she passed away. And she was in her 30s, I believe, but it started in adolescence. And but you can go back and view that whole thing. I don't believe it's that long, but I didn't think we had as slow as it was going. I didn't realize it was so slow, but I didn't remember that part. But you can go back and look at this, and it can give you a really good picture of what this looks like. And you know how people that have so much going for them can really have, even with all of that, they can have a poor self-esteem, and they can be trapped in this uh, scenario where they look in the mirror and think they're obese when they're not. But hope you get to look at that. Okay, so now we're going to look at the nursing process for anorexia nervosa. And we do have an assessment that we complete for anorexia nervosa. And thank you. And so we look at we really just look at the perception of the problem, a general assessment, and we look at the patient's perception of the problem. We have to really get down on their level and look at their social background, their eating habits. We have to get a dietary recall on their eating habits. We have to look at a history of dieting or purging, and they may be evasive when we're asking them about this, so we have to be careful and look, read between the lines, and uh, really be careful for how they're going to be evasive in answering some of these questions. We look at methods used to achieve their weight control. Are they purging in addition to just not eating? Are they using laxatives? Are they using thyroid medications that they're stealing from their grandmother or whomever? Um, and do they have some sort of ideal uh, shape and weight? Do they value do they have values attached to a specific shape and a specific weight? And then look at their interpersonal and social functioning, their mental status, and physiological parameters. And then look at how they see the problem, or if they don't see it as a problem. So we have to look at their self-assessment. Um, so again, the methods of weight control may often include control, restricting, purging, and/or exercising to the point that they're using all of their energy stores in the exercise and not not being able to hold on to any weight at all. But there are boxes that are important um, in your text. You need to look at boxes 18.2 and 18.3, as well as table 18.2 for more symptoms and behaviors. And these table 18.2 is on page 334, and then the box on 335 is important as well. Assessment guidelines, that will really just went over those. But table 18.2 on page 336 is important. And then considering culture, the box on page 336 is also important. So all of these boxes, just pay special attention to these because that's going to help you with your test. And then a continued assessment guideline. We have patient's perception of the problem. I'd already said that, but we need to really get their take on what they feel is going on. We have to make sure we get their vital signs. That's very important. Review of systems and appearance, and then screen for suicide or self-harm behaviors, because sometimes this can be a thing that is correlated with these types of because they're so intense. They're so intense on their physical appearance, and that is tied very tightly to their self-esteem. And their self-esteem can be so fragile when they're going through all of this. So they may have self-harm behaviors. And then look at their nutritional and fluid intake. If they get dehydrated, they're going to have fluids. And it is our job to investigate that, and because they may be not in the hospital when we see them, and they may be in a clinic. You may be working in a clinic and happen to see these folks, but very likely they will avoid clinics and try not to be seen, but you may see them in the hospital because they get into a crisis situation. Um, and then look at their daily activities, look at their lab testing, their laboratory testing, review that. And just again, boxes 18.2 and 18.3, as well as table 18.2, to look at those symptoms and behaviors. And then going back to her case study, during an assessment, Addie says, "This all started because my mom found out I fainted during gym class. It's ridiculous." This person, Addie, she seems genuinely unaware of how her low weight and other symptoms might be a source of alarm. She doesn't recognize the alarm. She doesn't recognize the harm that it's doing to her body. She doesn't recognize the danger. So Addie's skin is slightly yellow and her skin shows signs of dehydration. So this is very important. So the audience response question here, your practice question, with that fainting spell in mind, to further assess for anorexia nervosa, the school nurse should ask which of the following questions. Would it be, do you often wear heavy clothes in warm weather? Or B, when was your last menstrual period? Or C, do you use any drugs or alcohol? Or D, do you ever lose lapses of time? So think about this. We said amenorrhea often accompanies anorexia nervosa because they are not consuming enough nutrition to build the lining of their uterus so that they can have a normal period. So their body is in a wasting cycle, and they're not going to have a period because their body cannot afford to give up that blood or create that lining to give up those resources in their body. So they're not going to have a period. So the answer will be B. And another practice question: what is yellow skin and anorexia nervosa linked to? Is it lanugo? Is it amenorrhea? Is it the use of street drugs? Or is it hyperkeratinemia? And so the answer will be D, hyperkeratinemia. And so the rationale is that as anorexia nervosa progresses, the patient develops, among other things, hyperkeratinemia, which manifests as yellow skin. Lanugo, as we talked about yesterday or 2 days ago in class, that is fine body hair. Babies have this when they're premature and they are delivered premature. They have it in utero when they're, you know, in certain gestational stages, and it serves as a protective mechanism for their skin. When they're born too early, they have this, and it's just a fine body hair all over their body. Um, Amenorrhea is a loss of menstrual periods, and other signs of anorexia uh, occur due to other causes, including starvation and low weight. But so the answer is D, hyperkeratinemia. Um, And then for your nursing diagnoses, when you're taking care of these patients, they will include impaired nutritional status, impaired cardiac output, because their body is not getting the nutrition that they need. Their body is not getting the energy requirements that it needs to carry out normal processes. Um, and if they're so starved that their body is breaking down muscle mass, then it will be breaking down the the heart itself as well, the cardiac tissue. And electrolyte and fluids imbalance, we know that certain electrolytes will impact the cardiovascular mechanism, the heart itself for beating. We need certain, uh, we need a certain electrolyte balance and fluid balance to carry out cardiovascular function. Um, Also, disturbed body image, obviously and clearly, they have a disturbed body image. They are not looking at the reality of their body. When they see themselves in the mirror, they see an obese person. They don't see an emaciated person with no adipose tissue. Um, Ineffective coping, they're using this condition as a coping mechanism. Maybe, this is the one thing that they can control. Um, what they eat, their own body, they can control that, and maybe they don't feel that they can control anything else in their life, so they use this as a control, something they can control. Chronic low self-esteem would be a diagnosis, a nursing diagnosis that may be uh, relevant in this situation. Powerlessness, maybe maybe something that's that's important for your patient. And then other nursing diagnoses include disturbed body image, ineffective coping, chronic low self-esteem, and as I just said, powerlessness. Okay, so the outcomes identification. We would like to see improved nutritional intake, cardiac output, electrolyte balance, and fluid balance, and we would like to see positive body image, congruence between body reality, and that we don't want them to be living in an alternate world. We want to let them embrace reality. Um, and also effective coping and positive self-esteem. We want them to cope effectively. We want to teach them, or we want to put them in an environment that would be able to teach them effective coping. And there are some therapies that we're going to talk about, and then also positive self-esteem. And then your planning, we want to make sure that we understand the refeeding syndrome that I spoke to you about. Um, on Wednesday. Remember, refeeding syndrome is when nutrients are restored too quickly. Insulin stimulates glycogen and fat and protein synthesis, and this is a process that requires minerals such as phosphate and magnesium. But in severely malnourished patients, a refeeding syndrome may occur when we try to, um, you know, we try to introduce food too quickly, introduce food that is too rich for them to, their body has been kind of like in a state of shock because they've been starved. And so we have to refeed them very slowly with bland foods, with maybe liquid diets to begin with, so that their body doesn't become overwhelmed with the food that we give them, that it will be rich to their body because they've been starved. Um, and this is potentially a lethal complication, the refeeding syndrome is, and it may result in fluid balance abnormalities, abnormal glucose metabolism, and hypophosphatemia, hypomagnesemia, and hypokalemia. Thiamine deficiency can also occur, and so the reintroduction of nutrients are to be given slowly to avoid this refeeding syndrome. Now, remember, I said in history, when at the end of World War II, we had concentration camp victims that were found starving, and we also had prison camp. Let's see, they're called prisoners of war, and they were Japanese, and we had many of them. It was in the thousands, and we found that they were starving, so we tried to refeed them. We tried to save them from starvation, and we fed them too quickly, and a fifth of them passed away all at once. And so this was a catastrophe. This was not what was intended, but a fifth of them died because of refeeding syndrome. Their bodies um, could not uh, their bodies were overwhelmed, and they became, instead of responding positively to all of the food and the nutrition we were giving them, we gave it to them too quickly, and they passed away from the overload and the severe imbalances that occurred as a result of feeding them too much, or uh, too richly. We needed to feed them with clear liquid at first, and um, slowly increase their nutrition, because what we actually did was we caused them to die. So that was a real case history, a real history case. Those two cases, the uh, concentration camps as well as the prisoner of war camps that we intervened with. Okay, so your case study, going back to the case study, a question. Addie's condition worsens and she collapses at home. She is admitted to your unit with anorexia nervosa. You have completed your physical and biopsychosocial assessment of her. Which common personality trait is likely to present a particular challenge? And so is it lack of hygiene and cleanliness? Is it lack of interest in self and others? Is it irresistible desire to purge? Or is it perfectionism? And the answer here is perfectionism. The common personality traits of these patients are perfectionism, so they have a type A personality, obsessive thoughts and actions related to food, also intense feelings of shame because they've eaten, and people pleasing is a factor as well. And then the need to have complete control over their therapy. All of these pose additional challenges. So the control issue, remember I said that sometimes they feel they have no control, so they want control of something, so they use the food intake as a control, something they can have control over. And then some interventions that are used for anorexia nervosa. We want to assess and intervene with suicidal ideations first because uh, that is the most deadly of the ideations. If they have suicidal ideations, they could be at a real risk for committing suicide. So that's the most important thing at this point. Uh, Also, psychosocial interventions, pharmacotherapy, medication intervention would be important. We have the first line SSRIs that can be given. We have psychotherapy. Usually it's family therapy, and uh, there are other therapies that are introduced in your text. I need you to read the whole text. It's 17 pages. It's not that long. I need you to read those. Also, nutrition therapy, making sure that they are having that recommended registered dietitian nutritional uh, requirements that they prescribe, and then health teaching and health promotion, and then safety and teamwork. We have to work as a team. The family is included in this team effort. And then here are some specific treatments. The biological treatments include the pharmacotherapy. Um, Integrative medicine may include yoga, massage therapy, acupuncture, and bright light therapy. And then psychological therapies include the insight-oriented individual therapy, and then adolescent-focused therapy, the family therapy, as I mentioned, and cognitive behavioral therapy. Those last two are most utilized, the family therapy and the cognitive behavioral therapy. Those are the most commonly utilized therapies. But research does not support the use of pharmacological agents to treat the core symptoms of anorexia nervosa. Consequently, psychotropic medication is used to treat associated symptoms or other co-occurring disorders. So some of these medications, as I said, may include selective serotonin reuptake inhibitors, the SSRIs, the first line, and the anti-anxiety agents may be used. Second generation antipsychotics may be used, and also mood stabilizers may be used. And now we're going to look into bulimia nervosa. This is where they purge. The DSM-5 criteria defines this disorder as recurrent episodes of binge eating, recurrent inappropriate compensatory behaviors, and both occur on average at least once a week for 3 months. So they're purging at least once a week for 3 months. If that happens with this frequency, that is a criteria for being diagnosed with bulimia nervosa. Self-evaluation is unduly influenced by body shape and weight, so they see themselves again as disgustingly obese when they look in the mirror. They they don't like what they see. They see an obese, overweight person when in fact they are not, or most of the time they are not. Bulimia um, can be diagnosed along with anorexia nervosa, where they are very, very thin. Bulimia could be diagnosed by itself, and they might not be as thin, but they are definitely going to be malnourished because they're purging. And remember that purging does include and encompass the laxatives, the purging itself, the laxatives, the diuretics, as well as potentially the thyroid medication, the Synthroid and drugs related to Synthroid. Um, excuse me. And then the disturbance does not occur exclusively during episodes of anorexia nervosa. As I said, this bulimia nervosa, it could be along with the anorexia nervosa, but it does not have to be. So you can have bulimia nervosa by itself. And then as far as the epidemiology goes, the 12-month prevalence of bulimia nervosa among young women is anywhere from 1% to 1.5%. And the lifetime incidence of bulimia nervosa for women is 2.3%, and the lifetime incidence for men is only 0.5%. So women are definitely more susceptible than men. And bulimia commonly begins in later adolescence when the prevalence peaks into young adulthood. The onset of bulimia nervosa is rare in children younger than 12 and adults over the age of 40. So some of the comorbidity diagnoses that could be impacting this disorder include depressive disorders, anxiety disorders, bipolar disorders, and we'll study those disorders, I think, next week. But also alcohol and substance use disorders. And as I said earlier, post-traumatic stress disorder and other trauma-based disorders can also impact this disorder, bulimia nervosa. Also, borderline personality disorder. So that is covered in chapter 24, which we went over on Wednesday. But all of these can be comorbidities of bulimia nervosa, and it could be along with that disorder. The risk factors, generally the genetics, there is a 60% correlation of genetics in that impacts bulimia nervosa diagnoses. Also, neurobiological will impact, and then the cognitive factors, attachment challenges. Theories exist related to females not being attached to either one of the parents or both of the parents, and that's a theory that is accepted among medical professionals, that there is some sort of detachment or attachment challenge among the parents and the child at a young age. And then of course their self-evaluation, their own perception of the way they are shaped or the way they look as far as their shape and their weight. And they have a certain ideal that is not realistic. So the environmental factors include the internalization of a thin body ideal, and this will occur, in our media, in our just in our society in general. If we have a very prevalent ideal body shape, or like we value thinness so much. In countries that don't have enough food, that have starvation as a problem, you will not see anorexia nervosa or bulimia nervosa in those societies. You will not see that problem because they're just trying to have any nutrition at all. They're not going to be absorbed with these issues. But as I said earlier, the bullying is a problem. We have social media bullying that is prevalent in our society. And this can be a very real threat for young adolescent females, especially, but also males sometimes. We have bullying in all segments of society. I think I mentioned this. Even in nursing, we have bullying, and we should have a zero tolerance for bullying. But this is just what happens when person consistently and over time they are purging. There is an actual injury to their oral mucosa that occurs from the fingers being ram down their mouth and eliciting that gag reflex and then vomiting. And it has to be pretty aggressive to cause that reflex to occur. So you have over and over and over again, you have that recurrent uh, eliciting of the gag reflex. Well, that occurs and it can cause this tissue uh, to have injury, and that's what it looks like. Also, from the regurgitation of the stomach content and acid that it contains, it will cause these dental caries to occur. You see this etched enamel. The enamel starts to break down, and you have these dental caries that occur. And the fingers that is used over and over again will actually have a callus on the finger that will form, and that is called a Russell sign. And you may see this on a test, or you may see it on your NCLEX when you graduate. But this is just caused from purging so often that you build up a callus on your finger from doing that. So that's an important sign too. So we're going to go through the nursing process for bulimia nervosa. And so the assessment will include the patient's perception of the problem. Remember, we have to get their buy-in for the plan of care that we're going to implement. Otherwise, they won't comply. So we also get their vital signs, we get their systems review, and we look at their appearance and document all of that. We do a psychosocial history to try to get some insight into why this is happening, what are the triggers, what has happened to them that they feel that they need to do this, why is their body image disturbance so severe, why is their self-esteem so low. We get a nutritional and a fluid intake history. We get a history of their daily activities, and then we look at the laboratory testing review, and we look at all of that, and we look at the abnormal values and go from there. The diagnoses and outcomes include for nursing diagnoses and hypotheses. They include impaired cardiac output, electrolyte imbalance, disturbed body image, risk for difficulty coping, risk for powerlessness, low self-esteem, and risk for social isolation. And we also need to put in there risk for suicide in certain instances if it is severe, and it also includes the comorbidities that we discussed. The outcomes would be electrolytes imbalance, improved cardiac well, the outcomes will be that we want the electrolytes to be balanced. So electrolytes would be imbalanced, and improved cardiac output, improved body image, improved coping, positive self-esteem, that the patient verbalizes confidence in their self. We want them to be more confident. We want them to make informed life decisions, and we want them to express independent decision making and willing to call others for assistance. We need for them to be willing to call on someone that would give them help in difficult circumstances or in a crisis situation. We want them to develop a sense of belonging, and that is very important. Remember your Maslow's hierarchy of the Maslow's hierarchy. You remember that. Okay, so for the planning and implementation for inpatient care, we have to interrupt that destructive cycle. We need to replace that destructive cycle with a cycle that will heal, a healing cycle. Replace the bad thoughts with the good thoughts, and that is called mindfulness. That's one way to describe it. There's a medical intervention called mindfulness, and that is where you replace a negative self-thought with a positive self-thought. Also normalizing eating habits and setting them on a schedule and normalizing that. and also therapy for underlying causes. And that could be a lot of different types of therapies, as we mentioned earlier. Treatment of comorbidity, so that has to be addressed. Any comorbidity that they have has to be addressed also. Counseling is important, and that may include the family counseling, as I alluded to earlier. Um, and then help teaching and help promotion. And that is usually involves a lot of the nurse teaching, a patient teaching by the nurse. And that you'll be good at that. And then teamwork and safety. Safety is always paramount. We need to make sure that we're uh, identifying safety issues. That includes suicidal ideation. Um, and then advanced practice interventions, that would include your psychotherapy, and we'll talk about that too. Okay, so the pharmacotherapy, well, first of all, let's go to the biological treatment. The pharmacotherapy, we have antidepressants. We have the Prozac. We said that, yes, on Wednesday, we said that Prozac was the only FDA-approved medication for these disorders. We have other antidepressants that can be used. And we said that Wellbutrin would be contraindicated in bulimia because there is a possibility for seizures when using Wellbutrin. Wellbutrin is usually given to patients to help them with cigarette or stopping the smoking cessation programs. But in bulimia, it can cause seizures. So because of the dynamics of the fluid balance disruption and also the electrolyte disruption. So we don't want to give Wellbutrin. Just know that that's important. Your drugs are listed on or discussed in your text on page 342. And so remember that Prozac is the only FDA-approved medication for the treatment of bulimia nervosa symptoms in adult patients. It can be helpful for people with bulimia, even in the absence of depressive disorders. So remember that. That's the part of the reason that we include that. And we emphasize this so much because they don't have to be depressed to use the SSRIs and the Prozac. The psychiatric mental health advanced practice registered nurses are qualified to use the evidence-based cognitive behavioral therapy. And this is listed here on your screen, the cognitive behavioral therapy, or the CBT. This is considered a first line of treatment for bulimia, and when patients eliminate bulimic behaviors, issues of self-worth and interpersonal functioning become more prominent. So restructuring faulty perceptions and helping individuals develop accepting attitudes toward themselves and their bodies are the primary focus of this therapy. If early improvement is not seen with the CBT, an antidepressant is then added. So you do have the cognitive behavioral therapy, which trained nurses can implement with their patients, and then the mixed method approach for refractory cases that don't improve would be the medications and the continued CBT, and then others for other plans of therapy include the dialectical behavior therapy or DBT, and the interpersonal therapy or the IPT, and then acceptance and commitment therapy that's called ACT. But if I were you, I would focus on the cognitive behavioral therapy because that is something that the nurse can implement. Also, know about your Wellbutrin and know about your Prozac. Now we're going to go to binge eating disorder. And for this DSM-5 criteria, we have recurrent episodes of binge eating. Eating is a discrete period. Eating in a discrete period of time is important uh, to see when they're eating, and within any 2-hour period, an amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances. So we look at that. And then also a sense of lack of control over eating during this episode, along with a feeling that one cannot stop eating or that they can't control how much they are eating. So those two factors are included in the criteria for uh, for the diagnosis of binge eating disorder. Also, there's a marked distress over binge eating. They feel um, ashamed that they have binged in their eating. And then this occurs at least one time a week for 3 months and is not associated with any other disorder. So these are the criteria to diagnose the binge eating disorder. And also, in addition to that, for binge eating, episodes are associated with 3 or more of the following: eating much more rapidly than normal, and eating until feeling uncomfortably full, and then eating large amounts of food when not feeling physical hunger, and then eating alone because of feeling embarrassed by how much they are eating, and that also leads to the shame, and then feeling disgusted with oneself, depressed, or very guilty afterwards. So all of those. So you have to have 3 or more of these to be diagnosed with binge eating disorder. And then the cause of binge eating, the 12-month prevalence of binge eating disorder for adults in the United States is 1.6% in females and 0.8% in males. All of these disorders, these eating disorders, are more prevalent in women than men. For women, the lifetime incidence of binge eating disorder is 3.6%, and the lifetime incidence for men is 2.1%. And the presence of binge eating disorder is higher in overweight populations, which occurs at 3%. Than in the general population at 2%. All racial and ethnic groups seem to be represented fairly equally. Some of the comorbidities that could occur with binge eating include a specific phobia. At 37%, 37% of these individuals that are diagnosed with binge eating have a specific phobia. Also, they have a social phobia in 32% of the individuals diagnosed with binge eating. And then they have post-traumatic stress disorder in 26% of the individuals that are diagnosed with binge eating. Alcohol abuse or dependence is identified at 21% of all of these individuals that are diagnosed with binge eating. So this is very important too, because you're going to see this in your patients with this problem. And the environmental factors, social pressures to be thin, we talked about that, which are typically influenced through media. This can trigger emotional eating. And then social weight stigma, which is stereotyping or discrimination based on a person's body that is common in the U.S. and perpetuates the cycle of binging. Other factors include a history of trauma, particularly emotional neglect, and a history of food insecurity, which is the result of not having reliable access to a sufficient quantity of nutritious and affordable food. I think I mentioned that my cousin had adopted 2 babies, one from Russia and one from Thailand when they were infants, and both of them had been pretty much, deprived of food. The one from Thailand couldn't eat after or during the time that they were deprived of food. They had a problem where they could not eat after they were deprived of food. And so when she got that baby, he was on a feeding tube, or he would have starved to death. And but anyway, this one had a, a he had a problem with overeating because that was a coping mechanism for his psychological disturbance that occurred because of his time as an infant when he was in that orphanage. And anyway, they both had different issues. The one from Thailand was more fragile and had more problems, had hearing problems, vision problems, and anyway, it was just very interesting. But she wanted to help those who were in need. So she decided she could not have children. So she decided to adopt from those countries, those orphaned babies. And she did a good thing by doing that. They were better off, especially the one that had the feeding tube. He's a lot better off than he would have been. Um, but other risk factors for binge eating, there is a genetic predisposition and there's a neurobiological predisposition. As we just talked about, there are cognitive factors that impact whether or not people get binge eating disorder. And then there are environmental factors, as we just spoke about. Now, for the nursing process for binge eating disorder, of course, we have an assessment, and that assessment would include the patient's perception, as always, the vital signs, the systems review, and appearance of the patient in front of you, the psychosocial history, what kinds of factors has this person been through, any post-traumatic stress disorder that is likely due to that, nutritional patterns, history of weight cycling, and a history of binge eating triggers, foods, and frequency. And there is, on page 344, there's a box that talks about this assessment. And then on page 345, there's also a box on that page that you need to be recognizing and studying. And then the nursing diagnoses and outcomes will, as in relation to as it relates to diagnoses, we have impaired high nutritional intake, more than body requirements, disturbed body image, risk for difficulty with coping, anxiety, and low self-esteem, risk for powerlessness, and risk for social isolation. And so all of these will be on your NANDA sheet. And then for the outcomes, our outcomes should focus on nutrient intake meets metabolic needs, congruence between body reality and body ideal, and body presentation. And then satisfaction with body appearance, effective coping, reduced anxiety, positive level of confidence, and makes informed life decisions, willing to call on others for assistance. And this goes, with all of these, we need to have them to be comfortable with calling on others for help, because they could have a crisis situation where they could be in a situation where they may feel suicidal, or they may do something that's not good for them, and we need to have a plan for them to reach out to someone, and we need to identify those people that they could call on, and then develops a confident relationship with whoever that is. And then for planning and implementation, we need to plan for balanced intake and healthy movement. We need to avoid judgmental language. We need to recognize and have them recognize that binge eating is not about food, but it is about coping with their emotions. So with these individuals with binge eating disorder, they are using the food as a coping mechanism for their emotions that are not healthy, and they can't cope with the emotions that they are having. So we need to help the patient track what events triggered an episode and how they can manage those types of triggers, and then help the patient explore community activities or groups that would help them with their coping. And also use incremental approaches and goal setting. They need to have goals, just like we have goals. They need to have specific goals that they can work toward. And then help teaching and help promotion. That is your forte. That's going to be your area of expertise. And then your evaluation. And then for pharmacotherapy, uh, biological pharmacotherapy, the SSRIs, uh, sometimes, while they seem to help in the short term, patients regained significant weight gain after stopping the medication. Some evidence has been found to support the serotonin norepinephrine reuptake inhibitors, including Cymbalta or venlafaxine or Effexor XR, in treatment of patients with comorbid binge eating disorder, and major depressive disorder. Other medications that are under investigation include the tricyclic antidepressants and the anti-epileptic agents, such as I can't remember how to pronounce that. I did mention it in class on Wednesday. Dopacate. Let me look it up. I apologize, but it is a anti-epileptic agent. Anti-epileptic agent. I will look this up. But Vyvanse is a stimulant used to treat attention deficit hyperactivity disorder, and it has been used to treat binge eating, and it was approved by the FDA for the treatment of moderate to severe binge eating. These drugs are listed on page 346. And in regard to the Vyvanse, it was researched in 2017 and found to be effective. And the side effects, though, for this medication do include dry mouth, insomnia, a feeling of jitteriness and decreased appetite, increased heart rate, also constipation and feeling anxious. And there's a black box warning with this drug for having dependence, having increased abuse of this drug and dependence of this drug. So that's important to know. The drug that I was looking for is Depakote, and that is the anti-epileptic medication, but it is also used for other treatments of complex mental health issues. So the Depakote can be used in certain situations. The tricyclic antidepressants sometimes are not recommended for long-term use because of the possible side effects of tardive dyskinesia, which once that starts is a side effect which causes jerking movements and uncontrolled movements. And if that occurs, it's thought that that cannot be reversed. So that's the reason they don't use that as often, but they can use it if there's no other therapy that has worked for the patient. They can use it short term. Okay, so there is the treatment of surgical interventions such as bariatric surgery. That is a controversial option for the treatment of obesity. Sometimes it has bad outcomes, but while all persons who are obese do not suffer from binge eating disorder, research has linked individuals with eating disorders that undergo this surgery to possible complications such as impaired fasting glucose levels and high triglycerides and urinary incontinence. And sometimes there is death related to this surgery because of the complications. But then the psychological therapies include the cognitive behavioral therapy. That is very important for you to know. The cognitive behavioral therapy, know about that one. And then the dialectical behavioral therapy and the interpersonal therapy. So know those three, but especially the cognitive behavioral therapy and how that's used. And then these are more objectives. Describe 3 other feeding disorders. The pica or the pica, we talked about this in class. This is just when non-toddlers consume non-food items. Ice is people that eat ice, that is considered pica. Toddlers eat non-food items. They can eat paint chips off the floor. That toddlers put everything in their mouth. We're not talking about toddlers here. We're talking about adults. But pica can be any non-food item, dirt, clay, detergent, laundry detergent, anything like that, non-food, and they're eating it. That's considered pica. Pregnant women sometimes have pica. They eat non-food items. And so pica is not eating non-food items. That's abnormal. Rumination disorder, that is what we talked about in class that made y'all kind of sick. But it's a disgusting disorder where they eat and then they burp up the food and then they re-eat it, or they spit it out. But that's rumination disorder. And then avoidant restrictive food intake disorder. That's like the picky eater as a child. Think of a child being a very, very picky eater, and then take it a step further to adulthood. And there's a text box on 18.5 on page 348. I want you to be familiar with that. And then this is just really explaining pica a little bit more. Eating non-food items with well past toddlerhood, and it's not part of any other illness. And then this describes rumination, regurgitation with re-chewing, re-swallowing, or spitting. And then it has no medical or mental reason for it. And then avoidant restricted food intake, this explains that a little bit more. About 5 to 20% of children without other disorders may have the feeding disorder. Prematurity, failure to thrive, autism, and genetic syndromes result in ranges of 40% to 80% with feeding disorders. And there are not unifying etiology for food refusal, but personal anxiety and family anxiety seem to be risk factors. So it starts in childhood, and there 40% of picky eaters resolve on their own, and they have a low BMI. These people do, and then there is no distorted body image, but no distorted body image associated with this eating disorder of avoidant restricted food intake. Okay, this is just a Venn diagram that shows how these disorders overlap, and in some cases all 3 of them overlap, in some cases 2 of them overlap. So just look at this. This may be helpful for you to remember and memorize these disorders and organize them in your brain so that you can kind of recall this information on tests, and you can print this out and use it. And then this is also a grid that I used last year or the year before when I had a different text. But this is, I think this would be helpful to you to memorize some of this information and, kind of use it to quiz each other if you study together. And then if you study at home with your family members, you can have your family member quiz you on this so that you can memorize it. So this is a practice question. Hypoalbuminemia is in a patient with an eating disorder would produce which assessment finding? And the answer is D, peripheral edema. Peripheral edema often results from deficits of the protein albumin. And think about, swelling in your patients with other comorbidities. We think about, we think about decreasing their sodium and increasing their protein because the sodium causes them to swell. Well, in this, with an eating disorder, it would kind of be the same concept where they need more protein in staying in their body and to eliminate the swelling and their protein would improve their body condition. And then here's another one. Mr. Anderson, a patient living at home with dementia, is found to be eating laundry powder detergent on more than one occasion, and this is most likely a sign of which feeding problem. And so the answer is D, pica. And pica, as we said, is a feeding problem as opposed to an eating disorder. It's not an eating disorder, it's just a problem. And this involves the eating of non-food items and after maturing past toddlerhood. So if the person is not a toddler, then pica is a problem. Toddlers just have to be watched and made sure they're not eating non-food items. But with adult, the pica can be a major problem. It is not part of any other mental illness, though. Rumination is regurgitation of food, like we described earlier. And then binge eating and bulimia are two types of eating disorders as opposed to feeding problems. So that is all of my presentations for the video today. I know this was kind of long, but I want you to make sure that you do read your chapter 18. It's 17 pages. It's not that long. I want you to read it. I want you to reread it to have a very, very good understanding of what we're talking about. Remember your medications that are used for each of the feeding disorders or eating disorders, and make sure you pay attention to the boxes that I cited, and we'll do a review before your test in addition to this video. And thank you so much. See you next week. Be safe during the winter storm.